you want, you can start.
Okay, so thank you so much. Thank you, Fabio, for this introduction and for trusting me. I mean, I will express personal opinions inevitably, so feel free to make comments and criticism at the end or even throughout the presentation. I've been asked to talk about the context around which artificial intelligence is entering clinical medicine. I'm a medical oncologist, so clearly my perspective is the perspective of a clinical oncologist. So I will talk about oncology to some extent, but I think also that clinical oncology is a good model for contemporary medicine, which has undergone a deep revolution in the last decades. Once upon a time, there was the so-called science and conscience, which dictated what the physicians did and how they made their decisions. And I mean, clearly, all this has changed deeply in the last decades. We had medical schools. I mean, you know, from the very beginning of the history of medicine. I mean, there have been some medical schools which have been crucial for the advancements of clinical medicine, but up to a few years ago, if you want, people were talking about their medical school, so the medical school in, I don't know, in Bologna, in Padova, in Milan, and as if they could pursue I mean, a different kind of medicine from other schools. All this has almost disappeared, if you want. Conceptually speaking, from the publication of this randomized trial, which was the first randomized trial ever published on the British Medical Journal in October 1948 on streptomycin in pulmonary tuberculosis. The introduction of clinical trials in clinical medicine meant a lot. Many years later, again, the British Medical Journal posted an editorial claiming that clinical freedom had ended. And it's true in a sense, because from the introduction of clinical trials, it's the evidence gained through clinical studies what changes the state of the art, and the state of the art is more and more global and more shared across the globe. Also, of course, there may be discrepancies, inequalities due to economical reasons, of course, but aside from that. So a randomized trial is something which is aimed at minimizing the selection bias, the systematic error of selection. And if you control the selection bias, the statistical tests will take care of the random error, which is due, of course, to the variability of the biological and clinical reality. And this is the logic of clinical trials, which are experiments made in humans, following the scientific logic, so the logic of the experiment, the logic of testing an hypothesis. And again, the British Medical Journal, many years later, published this fake paper claiming that they did a meta-analysis of the trials published in literature about the use of parachute when you get out of an airplane. And actually, they didn't find any randomized trial. And so the evidence behind the use of parachute is only observational. This is something which I mean is obviously targeting some ideological interpretation of clinical trials made by the so-called evidence-based medicine, which has been a movement without clinical medicine around the 90s of the last century, which basically had the aim of undermining the value of medical authority through the scientific logic of experiments as clinical trials are. And the evidence-based medicine, in theory, in principle, says, okay, we gain evidence through clinical studies, but the clinical decision must take into account the individual clinical factors and the patient values. And so the medical decision is not automatic following evidence, so following the result of a clinical trial. By the way, evidence in medicine is not just about clinical trials. I mean, all what a medical student learns from anatomy to physiology to pathology and so on is evidence, if you want. But clearly the focus of evidence-based medicine has been the clinical trial as a means to change the state of the art. So clearly evidence is dominating, and clinical trials are dominating within evidence. And in the so-called pyramids of evidence, the RCT, the randomized clinical trial, stays on the top of the quality of evidence. And then you go downstairs with the uncontrolled studies, the observational studies, the biological rationale, and the expert opinions. By the way, being randomized is just a property having to do with the study design. So clearly the quality of a study is made also, of course, by a lot of other properties. And in fact, in some way, the quality of evidence is not just about the study design, but certainly in the pyramids of evidence, as a matter of fact, randomized evidence is better than non-randomized evidence. And clinical practice guidelines are based on evidence, are evidence-based. So each recommendation is based on a level of evidence according to the pyramids of evidence. And clinical practice guidelines set the state of the art in contemporary medicine. And by the way, many clinical decision support systems today are just incorporating clinical practice guidelines in order to provide the answer to the clinical case automatically through the electronic health record. Clinical practice guidelines, however, are also built on the consensus of experts. So clearly the recommendations must be evidence-based, transparently, but they are filtered by the consensus of experts. The consensus is something crucial for clinical practice guidelines. Thus, stressing that clearly evidence is not enough as long as you need the consensus of experts. So in some way, the subjective consensus of experts to interpret clinical trials and to interpret how they may change the state of the art in clinical medicine. At the same time, if you think of clinical ethics with the 4 classical principles of the 4 principles of doing the good of patients, not doing the harm of patients, respecting the patient's autonomy, and in some way respecting some criteria of fairness in resource allocation. You understand that these 4 principles are not necessarily complementary because sometimes there is a conflict among them. But clearly today, the principle of autonomy is dominating. So the clinical ethics today is based on autonomy. And if you want, from a paternalistic clinical model, if not authoritarian, but basically paternalistic, today the clinical model is a liberal one with some social influences, even simply due to the fact that many health systems, if not all, but at least most of them, are trying to become universalistic, properly universalistic, with the difficulties you all know very well. And so the importance, also the economical dimension in clinical decision making. At the same time, from the discovery of DNA to especially the sequencing of the human genome, molecular biology has undergone an explosion in clinical medicine. So from genomics to oldiomics, transcriptomics, metabolomics, also radiomics. Current molecular technologies are able to process a lot of biological material at reasonable costs, clearly with the use of artificial intelligence. Without artificial intelligence, this wouldn't be possible. And this has has given rise to the concept of precision medicine, with also, I mean, political relevance. At the beginning, the expression was personalized medicine. Then, around 2010, 15, it was felt that this was somewhat misleading because it would have meant going to the individual reality, which was too much, and so the label was I mean, precision medicine, mainly based on molecular biology, but also considering, of course, the environment to which the human being belongs and the lifestyles he or she follows. But clearly, molecular biology is dominating in precision medicine. Precision medicine has to do not properly to go to the individual patient, but at least to cluster individuals into subgroups, many subgroups, as many subgroups as necessary. If you want, you could say that personalized medicine is going even beyond, and so taking into account the individual patient's values and preferences, quality of life, and so on. But today, I mean, the idea is that precision medicine, and this is the guy who is claimed to have introduced the expression, with the, I mean, with the intent to rebuild clinical medicine, even in its taxonomy. So this famous report of the National Research Council in the US wished to create a new taxonomy of diseases based on molecular biology, going toward precision medicine. I would say, personally, at least my personal opinion is that this has not happened so far, and probably will not happen, even because in science, I mean, there is a lot of evolution. Yes, if you want, there are revolutions, but clearly, I mean, the taxonomy we use today is based, in any case, with bases which have been confirmed by molecular biology to some extent. Clearly, they have been refined. For example, I follow a disease, clinically speaking, which are sarcomas. And sarcomas have been histologically grouped in dozens of subgroups from decades, I mean, by the old pathologists based on the morphology, even before immunohistochemistry. Now, molecular biology is improving further, but it's not destroying what clearly marvelous pathologists many years ago were able to cluster quite correctly based only on the morphology of the tissues they were diagnosing. In medical oncology, precision medicine, precision oncology has much to do with targeted drugs, which have emerged from the year 2000. I mean, drugs targeting some receptors or pathways in the tumor cells specifically. So clearly, I mean, as a big progress medical oncology, I mean over chemotherapy, which you know was born after the Second World War, after the end of the military secret about drugs which were used in first in during the war. On the other side, today, so after 2010, 2015, immunotherapy is exploding, and if you want, it's possible that if this was chemotherapy in an advanced cancer patient with a solid tumor, and these were targeted therapies, so they improved, but then tumor resistance has been shown to be a big limiting factor. While immune therapy may work in less patients, but in those patients in whom it works, it may give rise to long-term benefits. And medical oncology has been accused in these decades of pursuing small benefits with very expensive drugs. In a sense, immune therapy is giving not only in hematological tumors, but also in solid tumors, which are the most common, is giving, at least in some patients, possibly with somewhat a less precise way of functioning, comparison to targeted therapies, which are very specific, but it seems to be able to even to cure advanced cancer patients in a proportion of cases, of course. But in any case, precision medicine is all about, I mean, going to the subgroups, to the outliers, if you want. I mean, is all about departing from the average patient. And the average patient is the subject of clinical trials. When evidence-based medicine was built as a concept and even as an ideology, if you want, to some extent, there were some physicians, some clinicians pointing out that this idea of the average randomized patient was a big problem, would have been a big problem. But there were not so many physicians picking up. And if you want, evidence-based medicine was largely built by methodologists, statisticians, epidemiologists, not so much by clinicians, I would say. And probably, I mean, with a kind of misunderstanding about the meaning of randomized clinical trials, and also with a big problem regarding the generalizability of clinical trials. I would say that there are two schools of thought in contemporary medicine about clinical trials. One says that the external validity of clinical trials should be such as to make their results exploitable in the individual patient, just because the eligibility criteria of the trial should be relaxed enough as to accept a wide variety of patients, So the large-scale clinical trial with relaxed eligibility criteria should be able to be generalizable, because I mean, if you include in your eligible patients also 90-year-old patients, okay, your trial will be generalizable also to 90-year-old patients, which is not true, because clearly, even if you put a couple of 90-year-old patients in a trial, this doesn't mean that the results of a trial are applicable also to the 90-year-old patients, first of all. And secondly, if you put too many 90-year-old patients, then the risk is that I mean, the results of your trial are, I mean, don't reflect the reality of the, for example, of the healthy patient of 60 years, in which maybe the treatment may work very well. And so if you want to demonstrate a survival improvement, I mean, with large eligibility criteria, you may simply not be in the ideal conditions of an experiment. No, if the randomized trial is an experiment made in humans, you should follow the logic of experiments in which you try to set ideal conditions. The assumption to some extent has been that from the randomized trial to the patient's bedside, there was nothing in particular. There was nothing like a physician able to use his or her clinical reasoning in order to translate the results of clinical research into individualized clinical decisions. On the other side, we have been always aware of the difference between efficacy and effectiveness. No, the efficacy of new treatments as demonstrated in clinical trials versus the effectiveness in the real world. So the efficacy translating into evidence from clinical trials, which then clearly will not translate into effectiveness simply because, I mean, will translate into effectiveness, but with some change in the outcome. I mean, due to the fact that the case mix will be inevitably different, and the performances will be different in the real world. And so, I mean, we have been always aware that one thing is clinical research and something else is outcome research, epidemiological research, and so on. And now the expression is the real world research. Real world research is certainly allowed by artificial intelligence, by the IT technologies, first of all, by electronic health records, but also artificial intelligence, of course. And so, in a sense, if a randomized trial minimizes the systematic error, no, the selection bias, and has some difficulty in coping with a random error because statistical tests cannot do everything, and the numbers in clinical trials is in any case limited. In a sense, artificial intelligence is the opposite. So you minimize the random error because you can deal with a lot of numbers, with huge numbers, a lot of cases, but you are exposed to any systematic error because clearly nobody randomizes in the real world. And so, and even more, I mean, if you know, your machine learning becomes too much a black box. And you know, the evidence-based medicine movement and the the theory of clinical trials always suggested to be, at least at the very least, very cautious about subgroup analysis, for example, because if you go too far with subgroups analysis, clearly the astrological birth sign will be important, no? For sure, you will find the statistical significance also for the astrological sign. And you know very well, how this may be a problem with also with artificial intelligence, clearly. So there is a clash in some way between evidence-based medicine and artificial intelligence because they are doing different things. They are pursuing probably different models of research, and it's quite interesting that there are not so many contacts today, or at least too many discussions between the world of evidence-based medicine and the world of artificial intelligence. And you know very well that artificial intelligence may substitute randomized clinical trials. I can only learn from Fabio about causal inference and all what at least a sector of artificial intelligence might allow us to learn. Certainly, medical statistics has not helped. So the medical statistics as built in the 20s, the 30s of the last century, and then implemented in the second half of the 20th century, has always been very convincingly frequentist. So the p-value, you know, is the probability we had to find the difference we saw if there were no difference, because the choice was to stay outside the Bayesian domain, no, the domain of the Bayes theorem, because of the subjectivity of the prior probability. So medical statistics has decided to stay within the concept of likelihood, so the p-value and so on. All the more as worked out then by Neyman and Pearson, because while for Fisher the p-value was just a measure of uncertainty, for Neyman and Pearson the p-value becomes a rule of choice. And it's difficult to make decisions without the Bayes theorem. And in fact, there was a big clash between Fisher and Neyman and Pearson, but today's methodology is based on their work. While on the other hand, the Bayesian solutions, Bayesian tools are more and more incorporated, as a matter of fact, into clinical trials, but without, a radical, interpretation of clinical trials as you could do in this way. So in practice, you could interpret the same clinical trial under an enthusiastic or a skeptical prior, and clearly in different ways. This kind of rendering of the results of clinical trials is not used today in general, although Bayesian tools are sure, but not in this way. In practice, I mean, by the way, it would be very difficult, of course, because in a sense, your trial results would change every day. I mean, because every day the prior would change because of the new knowledge gained somewhere in the world. So clearly, it's difficult to reason in this way, but the price that the frequentist statistics pay to refusing a Bayesian approach is that you are not talking about probabilities. You are talking about p-values and so on, but not about the probability that a treatment is effective. I mean, so not about probabilities as probability distributions affecting the risk of your patient with a given degree of uncertainty. You could reason, I mean, probabilistically in an explicit fashion through decision theory, decision analysis based on the, the decision and game theory, which has been, which was born in economy and then is used in several domains. In clinical medicine, it was proposed in 1959 with this paper on Science, published on Science. And then it has had a marvelous literature in the most prestigious medical journals. There is a medical society on medical decision making. There is a journal. There are handbooks, which, however, are much used in health economy, but not in clinical medicine. I would say not at the patient's bedside, in spite of efforts, I mean, to spread also among physicians the concepts of decision analysis, which clearly have to do with, I mean, structuring the clinical reasoning in a probabilistic way, so converting uncertainty into risk and valuing the patient's utilities. So in practice, fulfilling what would be a rational, personalized, patient-physician shared decision-making in conditions of uncertainty, which is the ideal of contemporary medicine, if you want. So the shared decision-making between the patient and the physician, valuing personal preferences and individualizing the decision as much as possible is the ideal of personalized or precision medicine, however you want to call it. Which, however, would, I mean, require a clinical method, which, I mean, my personal view is that it's difficult to build outside the decision theory, which, however, is not not been implemented in at the patient's bedside, at least. And so the orthodox idea was that a clinical trial results into a clinical algorithm. I understand that your use of the term algorithm may be a little bit different, but clinical algorithms are these very simple ways of I mean, structuring the state of the art in such a way that even before artificial intelligence, a computer would have been more than able to implement. But if the good clinical decision is actually a patient-physician shared decision in conditions of uncertainty, it's very difficult to reason this way, simply because any bit of uncertainty will undermine your clinical algorithm, either affecting the individual case or the evidence you have. Any bit of complexity will undermine your clinical algorithm at a time in which patients are more and more aged and so have a lot of diseases at the same time, take a lot of drugs. And the patient's willingness today is much more variegated than in the past. And so every physician in his or her everyday life has to make decisions which to some extent will be clinical, I mean, following clinical algorithms, but many times will not. They will not become decision analysis at the patient's bedside, but in any case, a physician will try to personalize as much as possible. And so you are left with this kind of clash, perhaps, between evidence-based medicine and artificial intelligence at a time when the big data technologies clearly evolve so rapidly, at a time when clinical decision support systems are entering electronic health records. And you can simply place inside the clinical decision support system a guideline. I know very well that companies doing clinical decision support systems are trying to incorporate existing guidelines, working with scientific societies and so on. So this is very simple, because incorporating a guideline, I mean, may help a physician a lot at a time when medicine is more and more complex. But clearly, I mean, if a clinical decision support system incorporates also a bit of machine learning, the temptation will be to learn from experience. You teach to me. And so, I mean, it's difficult to say when a clinical decision support system just improves the individual clinical decision, and when this means, on the other hand, to build new medical knowledge, and I would say that the border is very, very subtle. So in practice, artificial intelligence is clearly there to build new medical knowledge. But so far, new medical knowledge has been built through clinical trials in medicine. So, okay, artificial intelligence in some way will enter the field, but how, it's difficult to say. To which extent the two things, so the classical clinical trials will, will incorporate artificial intelligence, and to which extent the opposite may, the logic, for example, of minimizing some selection biases may enter artificial intelligence, is difficult to say today. And in the middle, there is a patient and the physician. In the 90s, I said that physicians were not very proactive in shaping the new evidence-based medicine. I fear that they will not be that proactive even with artificial intelligence. And clearly the risk is that something like that will happen also with artificial intelligence. I mean, something like what happened with evidence-based medicine. So clearly the technologies are there to dictate what will happen. It's impossible to resist a technology, a new technology. But even if not in the short term, there may be a price to pay in the long term, as there was a price to pay with an evidence-based medicine built, I mean, not considering, at least not enough, the reality, if you want, the real world of clinical medicine. Thank you.
Thank you very much, Paolo. Thank you for your presentation. It was very interesting to know the point of view of one that was active in the sector for many years and has such a deep knowledge, and try to reconcile what you know at the current stage with what is promised, not yet realized, obviously, but promised by developing new methods. Now I would ask to the attendee whether anyone would like to ask any question to the speaker. So we have, let's say, a quarter, 15 minutes for questions. So please do not be shy and ask your question to the speaker. So you have to use the chat if you want to make a reservation for asking the question. So please use the chat and ask, and then I will unmute you so you can ask the question.
Hope that everybody can.
No, yes, we have from Igor. Yes, wait just a moment, so I can unmute Igor. Okay, I can also stop the recording here, maybe better. Okay.